Adverse effects and tolerability profiles, similarities and differences will be the topic of his lecture. Professor Selçuk summarized the mechanisms, and Dr. Cengiz talked about the agents and the result of the agents in terms of response. I want to look at the picture from a different perspective and talk about side effects and tolerability, adverse effects and tolerability. Appropriate treatment, how do we define it? Adequate dose, adequate duration is required for appropriate treatment. In order to go up to the adequate dose, you should ensure that the patient is free of adverse effects. Adequate duration, for the patient to use the adequate dose for an adequate duration, the continuation of the treatment requires the lack of adverse effects and the presence of tolerability. Adverse effects and tolerability, in summary, are required for the appropriate treatments. There are many studies comparing antidepressants with one another, but when you look at the literature, you realize that the side effects, adverse effects, and tolerabilities of the antidepressants have not been compared with one another. Dropouts have been compared in order to interpret the tolerability. However, adverse effects have not been compared in one-to-one comparative studies. The reason for us to perform this analysis was this gap within the literature. We performed the analysis within the hospital population of Dr. Cengiz. We used the same patient pool for our analysis. Dr. Cengiz gave you the details about study inclusion and exclusion criteria. What we aimed with our analysis was to answer two questions. Our first question was, do different drugs have different adverse effect profiles? And the second question was, different drugs with different mechanisms of actions, do they also have different effects on the blood pressure and heart rate? Dr. Cengiz gave the details about the visits. We always took side effects. We took reports about the side effects. We performed blood pressure measurements and heart rate measurements at each visit. What were our findings? Dropouts due to adverse effects. The number of patients dropping out from the study were very minor. This was an open-label study. These open-label studies, where there are no placebos, in comparison, the open-label study, in open-label studies, the dropout rates have always been lower in comparison to the double-blind and placebo-controlled studies. They say that it is because of the bias. Therefore, please interpret our results in terms of our study design, which was an open-label study design. Side effect reports. For 10 weeks, reboxetine 461 adverse effects were reported. With sertraline, it was 80, venlafaxine 227, were the number of adverse effects. These are high numbers. These numbers were higher than the literature because at each visit, the patients were thoroughly asked about the side effects. The ratio of patients reporting at least one adverse effect. With reboxetine, all of the patients reported at least one adverse effect. This was 76.5% for venlafaxine and sertraline 58.7%. Reboxetine was higher than venlafaxine. Venlafaxine was higher than sertraline in terms of the patients reporting at least one adverse effect. Severe side effect, adverse effect reports. You see reboxetine is number 1 again. 16 people at week 2, 3 people at week 4, 1 person at week 7. Sertraline, 5 patients at week 2, 1 patient at week 4. With venlafaxine XR, no patients reported an adverse effect at week 2. At the 4th week, 1 person reported an adverse effect, but please do not forget that this is a time where the dual effect was expected to emerge. Adverse effect report percentages. What were the adverse effects reported? Insomnia. Yellow is reboxetine, red is sertraline, and the last column is for venlafaxine XR. Insomnia was very common with reboxetine, higher than sertraline and venlafaxine, but there was not a significant difference between sertraline and venlafaxine in terms of insomnia. Dry mouth was significantly different between the 3 groups. Reboxetine was number 1, venlafaxine was number 2, sertraline was number 3. Constipation was not reported with sertraline. With reboxetine and venlafaxine, it was reported with perspiration. Sertraline, no reports, but reboxetine and venlafaxine were significantly different. Palpitations was only reported with reboxetine. The other 2 agents, the patients using the other 2 agents did not report palpitation. Nausea, there is a reverse profile. Venlafaxine is number 1 in terms of nausea. Flushing, typical adrenergic effect, seen with reboxetine only. Feeling of dizziness, venlafaxine was number 1. Ejaculation, delayed ejaculation, only reported with sertraline. Again, a significant difference. How did these adverse effects were influenced throughout the study? Was there a tolerance to these adverse effects? Insomnia, one of the most prominent effects of reboxetine at the early visits, decreased in the following visits and went below 10%. Dry mouth, again, no tolerance for reboxetine, but with venlafaxine, dry mouth complaints decreased, still higher than 10%, about 20%, but there's a significant decrease. Orthostatic hypotension, nausea, sertraline, there was a fall in nausea. After week 7, no reports were submitted. Tolerance had set. Headache. With venlafaxine, went below 5%. Nausea went below 5%. Headache was observed with reboxetine, but went below 5% from 15%. However, flushing, hot flushes, no tolerance with reboxetine. Distress, anxiety with sertraline, very high. But after 2 weeks of the first dose, no reports for anxiety. Feeling of dizziness, venlafaxine, very high. No tolerance. Although the graphic seems to show a significant difference, graphic changes between 0 and 25%, therefore there is no statistical difference. What about the vital parameters, heart rate, reboxetine? When you go from 4 milligrams to 8 milligrams, there is an increase in comparison to 4 milligrams. But when you look at it throughout the study, there is no significant heart rate change in comparison to the baseline. Sertraline, there is the reverse effect. At week 2 and at the end of this study, there is a decrease in heart rate. With venlafaxine, there was no statistical difference. Increases and decreases are important, but what about its clinical impact? Those patients with heart rates above 100, what about them? What is the picture with them? At the end of the study, these patients, at week 10, the patients having heart rates over 100 at the baseline, their heart rates go higher, up by 18%, from 3.8 to 18%. The others do not show this effect. But this might not also have a clinical meaning. The most important thing is the increase in the ratio of the heart rate, resulting in a heart rate higher than 100 per minute in comparison to the baseline. When you look at the percentages, there are no differences between the different arms. But this is a 10-week study, and also reboxetine, with 5 patients receiving reboxetine showed this effect. Beyond 10 weeks, maybe new patients could have been added on at the reboxetine arm, and thus causing statistical significance. What about blood pressures? Systolic blood pressure, interestingly, we could not see any difference with reboxetine. We're talking about a noradrenergic agent. At the suggested dose of 8 milligrams, we could not see a systolic blood pressure increase. Interesting, but can be discussed. With sertraline, there is a decrease in blood pressure. There is confirmatory literature. The significance reaches significance at it does not reach statistical significance, but it becomes close to statistical significance at week 10. With venlafaxine, at the 4th week, where the patients have been using 150 milligrams for 2 weeks, there is a significant increase in comparison to the baseline, and the significant increase is also observed at week 10. There is a systolic blood pressure increase with venlafaxine. What about diastolic blood pressure? No differences were observed with reboxetine and sertraline. With venlafaxine, at the 4th and the 10th week, there are significant increases. What is its clinical meaning? In order to measure this, we define persistent hypertension. American Heart Association has a persistent heart association definition. If diastolic blood pressure in 3 consecutive measurements has increased more than or equal to 10%, going beyond 90 millimeters of mercury, then this can be called persistent hypertension. Or this should be a warning about persistent hypertension, is recommendation of the Heart Association. Again, no significant difference, but I should warn you, had the study been larger in size, then perhaps it would have reached significance. In conclusion, what can we say with the data at hand? First of all, reboxetine has had the most numerous adverse effect reports. With reboxetine, there were more severe adverse effect reports. Everyone using reboxetine reports at least one adverse effect. What does this mean in terms of clinical practice? If you are prescribing reboxetine, then your patient will complain of at least one adverse event in the second visit. Sertraline has the lowest adverse effect report numbers. What about venlafaxine? Adverse effect was lowest with venlafaxine. But the severe adverse effects were lowest with venlafaxine. Dropouts. Cipriani's study in 2009, similar to our patients, meta-analysis of the dropouts. Reboxetine was higher by 1.75-fold from sertraline. Reboxetine was 1.1-fold over venlafaxine, and venlafaxine was 1.78-fold more in terms of dropouts in comparison to sertraline. This is the results of Cipriani. What was the answer of the first question? Different drugs with different mechanisms of action, do they have different adverse effect profiles? This is the picture we have at hand. Venlafaxine seems to have a specific adverse effect. With reboxetine, flushing, hot flushes, palpitations seems to be reboxetine related. Ejaculation, delayed ejaculation, anxiety seems to belong to sertraline. Sertraline and reboxetine seem to share insomnia. Sertraline and venlafaxine seem to share nausea and sedation, and headache seems to be the common adverse effect between the three. 150 milligrams per day venlafaxine, dizziness, nausea, headache was common. The first is serotonergic and the second is noradrenergic. But when you look at the report numbers, we see that the serotonergic adverse effects were less than sertraline and noradrenergic adverse effects were less than reboxetine. What about tolerance, development of tolerance? In reboxetine, insomnia and headache, there was tolerance. Sertraline, nausea and feeling of distress, there was a tolerance for these two. And with venlafaxine, dry mouth and nausea, there was a tolerance. So, if your patient reports any one of these, then if the patient has the patience to wait for 4 weeks, then you can go on with your drug. This is the clinical meaning of the results. Sertraline seems to decrease systolic blood pressure and heart rate. It is known to block sympathetic system, and it's also known to decrease plasma norepinephrine. Venlafaxine increased blood pressure. Was there persistent hypertension? No, we cannot say that there was persistent hypertension with venlafaxine. With reboxetine, patients with tachycardia were higher in number, but did it have a clinical meaning? We cannot say that. Do not forget that we looked at open label studies, and the cases were 50 patients. The sample size was 50 patients. My suggestions: all three drugs had adverse effect profiles in parallel to their mechanisms of action. Some of the adverse effects had tolerance developed. Some of the adverse effects, the patients became more tolerant to some of the adverse effects. In clinical practice, the vital parameters need to be closely monitored before starting.